Hello, everyone. Welcome back to another day of our NCLEX review session with Stancoast and NCLEXcoaching.com. For those who just started joining us in our YouTube channel, please kindly visit the website that we have at www.stancoastandclexcoaching.com. We are offering the course there, which you can access for this 6-month period. And today we will be tackling a part of the hematology concept. And just to let you know, we are on the 44th of the 90-day free NCLEX sessions that we are reviewing. And so just letting you know that we tackle a variety of nursing topics. And we just want you to enjoy our perks and also the services that we offer with your subscription. And so you will be able to access 3,000 NCLEX-style questions and also the on-demand videos that we have with a course included. And so we really aim to boost your confidence with our resources. Now, for additional details, kindly click on the link below in the description box. And we always welcome your feedback, your thoughts, and also your comments. So kindly post them in the comment section. And please don't forget to subscribe, like, and also share this video with your friends who are reviewing for the NCLEX. Now, today we will be tackling on the Hutkin's lymphoma. For those who just came into the classroom, good morning, welcome back. And this is a disorder which is actually a type of cancer that can start in the lymphatic system. And this is really crucial for the fighting for the infections. And I'm talking about the lymphatic system. And so the Hutkin's lymphoma is actually invading into the lymphatic system. And here's what you really need to know about the disease itself. So when we are talking about the age distribution, well, the Hutkin lymphoma can affect two main age groups. And so here you will see that X1 15 to 30 years old. So these are the young adults that can be at risk to developing the Hutkin's lymphoma. And we also have the X2, which is basically those older adults above 50 years old. And so this means that the problem can strike younger people just starting out in life as well as older individuals. Now, as we were going to talk about the lymph node history and also the subtypes. So this is actually histology, lymph node histology. Correcting that. Now, the Hutkin lymphoma basically has different subtypes, and this is based on how the cancer can look under a microscope. And so one of those subtypes are the following. So we have what we call as the lymphocyte predominance, and this is consisting about 5% of the cases. And this has few Reed-Sternberg cells, which are actually the abnormal cells in the Hutkin lymphoma, and also many normal B cells. So please take note of that. That's about the lymphocyte predominance, which is about 5% of all cases. Now, take note here that it's less common, but usually has a better outlook. I'm talking about the prognosis here. Now, another subtype here is the nodular necrosis, which consists of about 70% of the cases. And so this is common in women, and this type of the lymphoma shows more collagen bands, and they're going to be around the Reed-Sternberg cells as well. And this will often affect the young adults and will generally respond well to the treatment. Now, as we are talking into another subtype here, which is the mixed cellularity, which is about 25% of the cases, it means that there are so many Reed-Sternberg cells, and this is going to be mixed with other cell types. Now, with this kind of subtype, this is going to occur more in the older adults. Okay, mixed cellularity will occur more in older adults. And also the treatment outcomes can vary greatly. Now, another subtype here for the Hutkin lymphoma is the lymphocyte depletion, which is less than 1% of the cases. It simply means that there are few normal cells that are present, and there are many red Sternberg cells. Several red Sternberg cells. So I'll show you real quick later on about what that is, okay? And with the Hutkin lymphoma, we need to know about the staging, okay? And this is based on the Ann Arbor system, which is basically the standard in staging the disease. This is what we call as Ann Arbor system that the medical providers, the oncologists will use in measuring the degree or the severity. And so this is going to determine how much the cancer has spread into the body. So when we are gonna see a stage, like a stage 2, okay? Actually, that is stage 1. I'm not seeing quite clearly right now. So this is basically stage 1. It's correcting that one. That is stage 1. So that simply means that the person has at least a cancer that is found in one lymph node, or maybe in one part of the organ outside the lymph nodes. And this is what we call as the milder stage, right? And then we also have the stage 2, which simply means that the cancer is found in 2 or more lymph node areas. And this is going to be found on the same side of the diaphragm. And we also have the stage 3, which is basically the cancer has been found in both sides of the diaphragm. And lastly, we have the stage 4, which is basically the most severe type or stage, which simply describes that the cancer has spread widely into more organs in the body and also outside the lymphatic system, okay? And so the liver cells, the liver, the lungs, or also the bones are greatly affected here, okay? So please take note of the severity in the different stages. Now, take note, guys, that with the Hutkin lymphoma, we're going to find this out, that especially when the patient is first diagnosed, they're going to complain about this painless lymphadenopathy. Basically, this is what we consider as the most common symptom of Hutkin lymphoma, and this is what we call as Hallmark symptom. They're going to feel this enlargement of the lymph nodes, okay? This is going to be painless. Please take note of that. This is the hallmark of Hutkin lymphoma. And of course, this will present as the enlargement that are painless. And this can be specifically found in the cervical lymph nodes, or let's say the supraclavicular above the clavicle. In some cases, it can be found in the cervical lymph node site, maybe in the axillary region, or in the chest cavity, the mediastinal area. So here are the different spots where you can assess those painless but enlarged lymph node. Now, I really want you to review here with a physical exam that normally the lymph nodes are not, they're usually not palpable if they are less than 0.5 to 1 centimeter. That is very tiny. But whenever they're going to have the Hutkin lymphoma, these lymph nodes are actually getting bigger. Again, it's painless, so sometimes people will just ignore it because it's not really bothering them. And with the lymphadenopathy here, it tends to spread from one group of the lymph nodes to adjacent groups, so from one region to another region. Now, another is that there are going to be some B symptoms. So what are these B symptoms? This pertains to the systemic symptoms that can include the following. Maybe the patient will complain about fever that is going to be persistent. So it doesn't seem to go away when they're going to have this kind of fever. They would not even identify an obvious cause for the fever. And usually the fever can become intermittent, okay? It becomes intermittent. And the temperature ranges would be about 102 to 104 degrees Fahrenheit. 102 to 104 degrees Fahrenheit, or let's say 39 to about 40 degrees Celsius. So that's how the fever is characterized in the Hutkin lymphoma. It is persistent, it is intermittent. And the fever doesn't seem to get associated with other problems. Now, the patient will also complain about night sweats. Basically, they're going to end up with a profuse sweating at night, and they're going to end up with extent soaking through their clothes, or let's say beddings. And they're also going to manifest some weight loss, and this is unintentional weight loss. So, patient would probably wonder, hey, what's going on with me? I'm not really doing a whole lot of exercise, but I'm losing a lot of weight, and I'm not disliking it, just kidding. But yeah, the weight loss here is unintentional, and the loss will be exceeding about 10% of the body weight, okay? And it can span for over 6 months. And so this is going to be a gradual unintentional weight loss for a period of 6 months. So basically they're probably not going to pay attention to this because it's gradual, it's nothing abrupt. So they're not going to worry about this. Now, another problem that is under the B symptoms, we have actually, it's a totally different group of manifestation. Pruritus is another manifestation here. Basically, the person will end up with this massive itching. And of course, this is particularly after consuming an alcohol, and it will be much more aggravated. Now, another is coughing, which is basically a persistent cough. And this is going to develop due to the involvement of the mediastinal lymph nodes. Involvement of mediastinal lymph nodes. Okay. For those who just joined us, I'm seeing new names here in the classroom. Welcome to our session today. We're talking about the Hutkin lymphoma. We are tackling the hematology concepts this time. And so you're welcome, and you are free to review our previous videos that we've had. We had already 43 sessions, so kindly visit the tab in our website. We have all the recorded videos there from the live sessions. All right. Now let's move on to the next section of our discussion here, which is basically on the diagnostic test. And so the detection of the Hutkin lymphoma starts with the lymph node biopsy. And this is going to be the definitive diagnostic test of the Hutkin lymphoma. Hello, everyone. Good morning or good evening. Virtuous Lady is in. V. Denkira. Hello. Sia. Miss Chica. Roberta is in. Or Ruth. Noah Kago. Adiola. Neje. Who else is in the room? And I believe Kashmir was earlier in the room. Okay, welcome. Now, with the lymph node biopsy, like I've said, this is the definitive diagnostic test. Okay, so what is the significance of the lymph node biopsy? Well, this can detect the Reed-Sternberg cells that I talked about earlier. So it has that characteristic owl's eyes. There's Joyce, there's Anita, I'm Puma, welcome. Do you notice the section right here? Basically, let me remove that one. I just want you to take a look right here, right where the arrow is pointing at. So you can see here two beads, like bead appearing kind of structure, and it has the owl's eyes. Okay, can you see that similarity here, the resemblance of owl's eyes? That's basically the description of the Reed-Sternberg cells microscopically. Okay, so basically they are large, they are abnormal cells that will have multiple nuclei. Multiple nuclei. And this is really what sets apart the Hutchin's lymphoma from the non-Hutchin's, okay? The Reed-Sternberg cells. And the lymph node biopsy can also determine any of the inflammatory cell infiltrates, which is going to really distinguish the Hutchin's lymphoma from the non-Hutchin's lymphoma. And so this is really the distinguishing characteristic of this type of cancer. All right. Now, another diagnostic test that we'll have out is the use of the chest X-ray. And this is the most initial imaging study that can assess any mediastinal involvement. Assesses mediastinal involvement, especially if there is now a spread of the cancer cells into the mediastinal lymph nodes. Okay, mediastinal involvement. And again, chest X-ray is going to be part of that as well. Now, another is CT scan of the chest. So, of course, if there is a suspicion that the cancer cells have spread into the lymph nodes of the chest, well, the CT scan of the chest will give us a better idea, much more detailed imaging, and also, let's say, abdominal CT scan or maybe the pelvis. And this is really going to assess if there is now extent of the disease spread and also the severe spread of the lymph nodes in those various organs. Now, another is the bone marrow biopsy. So what is this? Well, basically, the doctor will have to determine if the bone marrow is involved by the Hutchin's lymphoma. And so it will show here the infiltration of the Hutchin cells in the bone marrow. It will show infiltration of Hutchin cells in the bone marrow. Okay. And this is going to show us that maybe the disease has already been kind of more advanced. All right. Another diagnostic test will be the use of the complete blood count, where it will show eosinophilia. There is going to be an increase in the white blood cell count. Even though that it doesn't really universally occur, but it is a common manifestation. It is a common diagnostic result. The reason for that, it's because of the inflammatory response due to the lymphoma. So I want you to recall the different diagnostic tests here. Recall about the Reed-Sternberg cells, which is the hallmark diagnostic sign in the Hutchin lymphoma. We also have the classification here. Don't forget about the distinguishing inflammatory cell infiltrates, and also with the other imaging studies and the bone marrow biopsy and the use of the CBC. Okay, don't forget those. Now, we're going to talk about the different treatment modalities for the Hutchin lymphoma. Well, one of those will be the radiation, one of the mainstays here, and we also have the chemotherapy, which is going to include the ABVD. So what is the ABVD? This will include the following medications. We have the adriamycin or the doxorubicin. We also have the bleomycin, the vinblastine, and the dacarbazine. So we'll talk about each of these medications individually. Again, don't forget about the ABVD. This is the chemotherapeutic modality that will be used for the treatment of Hutchin lymphoma. So let's talk about the adriamycin or the doxorubicin. So basically, this is an anti-cancer medication. It is an anthracycline chemotherapy. So I want you to focus into the words here. Anthracycline chemo drug, which can damage the DNA of the cancer cell. And we are talking about the adriamycin. And this medication will now prevent the cancer cell from dividing and also multiplying. Prevents cell multiplication and division. All right. As we know that cancer cells will tend to go into that pattern. And this is a medication that is given IV. Now, we'll talk about the bleomycin. What is this drug? Well, the bleomycin can also interfere with the division process of the cancer cells. Interferes cancer cell division. And of course, it can damage the DNA as well. And it is going to be given as an IV drug as well. Now, we're going to talk about the vinblastine. What is this medication, which is part of that chemotherapeutic modality? This is going to disrupt the microtubule structures. Disrupts microtubule structures in the cancer cell. And also, it will prevent the division and also the growth of the cancer cell. Prevents division and growth of cancer cells. Don't forget about that. And then lastly, we have the dacarbazine. Sorry about the arrows here, but trying to find a space. So the dacarbazine is also going to alter the DNA replication of the cancer cells. It will alter DNA replication. Of course, it can also destroy the cancer cell at the end. And the drug is also given as an IV. All right. Now, if we were going to ask what will be the schedule or how often will the patient be getting this type of chemotherapeutic agents? Well, the chemotherapeutic agents will be given in cycles. So it will be given in different days, or let's say every 2 weeks. And the duration of the chemotherapy, it will depend on the patient's response and also the stage of the Hutchin's disease. So let me clear this out here. Let's talk about the frequency and the duration. Again, it will vary from one patient to the next. For the frequency, it will be according to the cycle, which is going to be every 2 weeks. And the duration for the treatment is going to be varied. It will be dependent on the patient's response and the severity of the disease. But most often, the duration will span for several months. And of course, what is the indication for the ABVD, the adriamycin, the bleomycin, vinblastine, and the dacarbazine? Well, it is indicated for the Hutkin lymphoma, which is very effective, especially for this classic type of lymphoma. And we have to take note also that these medications can also cause some major side effects. So we'll talk about the side effects this time. What are those side effects? We can identify those most common ones. You probably know already about the nausea, vomiting. So let me put those in. The side effects in general for all the ABVD. So here we have the nausea, the vomiting. There's also hair loss, just similar to the other anti-neoplastic agents. The patient will also have fatigue, and they're also going to be increased susceptibility to infections. Of course, it's because of its effect into the what? The bone marrow, which actually will produce the red blood cells, the white blood cells, and the platelets. So they're going to end up with a higher risk to getting those infections. Now, other effects will be kind of long-term. And so this can also lead to the person's infertility. All right. Infertility. That is another one. It could lead to heart damage. And also the development of secondary cancers. Secondary cancers. So even though they're treated with the ABVD, well, the side effects can also lead to the development of new cancers, secondary cancers, we should say. Now, as you are already seen the side effects here, the frequency, the duration, what do you need to know about this patient getting the ABVD? Well, we really need to make sure that our patient is properly monitored. So we are going to educate them about the monitoring of their blood counts. That is very important, guys. So let me put that as part of the nursing care. One is monitoring, and we are talking about the blood counts. Okay, don't forget about teaching them that they need to be compliant with the schedules when they're supposed to have the blood draws. And we also need to, I'm talking about the complete blood counts here, the white blood cell, platelet, red blood cells, because this can cause a drop in the cell counts. Another would be to check the liver function, okay, because this can also cause problems into the liver tissue, and we need to make sure that our patient is not going into some sort of a liver failure or other issues. And we also need to help in the management of those manifestations, especially those side effects, right? So we need to manage their nausea and vomiting. We're going to have to educate them on how to, or what medications that they should be taking in order to prevent the nausea and vomiting. So we're going to have to teach them about the medication regimen, meds for nausea and vomiting. And of course, if there is going to be a secondary infection because they are prone to get these opportunistic infections, then we're also going to educate them about the antibiotic therapy, antibiotics. And also we're going to have to educate them about those growth factors to support the blood cell production, because they're prone to developing the anemia, and we need to tell them about or instruct them about these new medications that can help boost their red blood cells. Okay, now we're going to move forward with our discussion here regarding the non-Hutkin lymphoma, which is another kind of lymphoma. And this is a type of cancer that is going to be so diverse. It has so many different groups of solid tumors. And this is going to be much more difficult to treat compared to the Hutchin's lymphoma. And these are the different groups of the solid tumors. One is the malignant transformation of the B or the T lymphocytes. There's also going to be the B cell lymphocytes, which consist about 85% of the cases. And for the T lymphocytes or T lymphomas, it can lead to about 15% of total cases. And the non-Hutchin lymphoma will start in the lymph nodes as well, and also affecting the blood and also the bone marrow. So this is how extensive the non-Hutchin's lymphoma, okay? It will start in the lymph nodes, it can spread into the bloodstream and into the bone marrow. Now, we'll talk about the prevalence and the mortality of the NHL. Well, it is identified that the NHL is considered as the 6th most common cancer-related death in the US. So don't forget its mortality rate. And this is going to occur twice as common as the Hutchin disease, and more likely will be advanced when the person will manifest the symptoms. Okay, so it's quite more deadly or deadlier than the Hutchin's lymphoma. Now, talking about the different risk factors here, one of the following is the HIV, AIDS, also immunosuppression, maybe because the patient is taking any immunosuppressant medications, possibly because of the um, taking of these anti-rejection medication. Okay, anti-rejection drugs. For those who are who had the kidney transplants, yeah, they are prone to developing the non-Hutkin's lymphoma because they are using the anti-rejection medications that can cause immunosuppression. Again, please take note, guys. For those people who had organ transplants, maybe kidneys or any other organs that they're getting, they're going to take the anti-rejection meds. But these medications can lead to immunosuppression. So this person will be at risk to developing the NHL. Now, another risk factor here is the Epstein-Barr virus. We also have the Helicobacter pylori, which is going to cause a lot of problems in the stomach. Basically hard to treat, guys. This is a bacteria that can do a lot of havoc inside the body. And we talked about this in the previous topics in the platelet and also the coagulation problems. Remember about that antibody formation because of the Helicobacter infection. So I want you to go back to that concept if you've forgotten about that. Now, autoimmune disorders can also lead to the development of the non-Hutkin lymphoma. Now, this time, guys, we'll talk about the classification about the NHL. So we're going to start with the low-grade lymphomas. So here, it's said that the cure is rare, and the median survival rate is about 5 to 7 years for the low-grade lymphoma. And as we're going to move along to the intermediate grade lymphomas, this will require so much more of aggressive therapy. It will cure about 50% of the patients, 50%, and a survival rate of about 2 years. That's not a lot, 2 years. And if we're talking about the high-grade lymphomas, this will require much more aggressive chemotherapy, radiation, but it can also cause a cure about 70% of the cases in patients. However, though, the median survival rate for the high-grade lymphomas without treatment, okay, without treatment, it's about a few months. And so our patient's lifespan here is very short, all the more without the treatment. Again, we're talking about the high grade. So this is the most severe form of the NHL. Now, as we're going to talk about the different assessment findings, again, the person will probably just report, hey, I have this kind of growth in my neck area. It's not painful, and it is firm. It's mobile. And this can pretty much affect those lymph nodes somewhere in the supraclavicular area, or could be the cervical or the axillary lymph nodes. And again, it will also affect one region to the next. Now, the patient here with the NHL, they're also going to be manifesting the B symptoms like we talked about earlier, but they are less common in this patient with an NHL. They can still have the B symptoms, but less common. Now, they're also going to manifest the enlargement of the spleen, the liver, and once the cancer cells have spread into the bone marrow, then this is the time that they're going to manifest a drop in their red blood cells. Their hemoglobin will be critically low. Their white blood cell count, the leukocytes, the neutrophils will also be decreased. And the patient here will be prone to getting the opportunistic infections, and the patient will be prone to developing bleeding tendencies because of the thrombocytopenia. Okay, so don't forget about the 3 blood groups that will be affected whenever there is bone marrow involvement with a NHL. Now, as we go along here, the diagnostic tests are the following. There's going to be lymph node biopsy, and as I've said earlier, the biopsy will be determining, it will detect that the size of the lymph node basically is greater than about 1 centimeter. Greater than 1 centimeter in size. And the patient here will also require some imaging studies. We have the chest x-ray, the CT scan of the chest, the abdomen, the pelvis will also help in evaluating the severity and also the spread of the cancer cells. There's also a need for the bone marrow biopsy to check for the spread of the cancer cells into the bone marrow itself. And we are going to check the other lab test. The patient here will have an elevation of the alkaline phosphatase. So this simply means that the person is now having bone or let's say liver involvement. Okay, take note about elevated alkaline phosphatase. And the person might have elevation of the liver function test, those liver enzymes, of course. It's going to tell us that the patient now has spread, it already has the cancer cells into the liver, right? The person will also will have some anemia. There's going to be a drop in the white blood cell count, a drop in the platelet count, and I'm not talking about just like a slight drop. No, their values are going to be very low at this point whenever there's bone marrow involvement, I should say. Okay, so please don't forget about those blood counts getting low. Anemia, leukopenia, and thrombocytopenia. Now, let's talk about the different treatments here for the non-Hutkin lymphoma. So when we are talking about the indolent type of a non-Hutkin lymphoma, this is considered as the mild type, right? They said that it's kind of rarely incurable, or rarely curable rather, and it's known to have, let's say, 5-year survival rate with a 75%. Okay, 75. Hang on a sec. The indolent non-Hutkin lymphoma has a survival rate of 75%. All right. And the treatment here will include observation. They're going to undergo chemo and also radiation. So those are the treatment modalities for the indolent, the milder form. There's also the intermediate and high-grade NHL, which is going to require the more aggressive type of chemotherapy. And they're going to, the survival rate here for this person with the high grade or the intermediate will be less than 2 years if they are not responsive to the therapy. Less than 2 years if not responsive to the chemo. Very shortened lifespan, 2 years. And here we're going to expect that the patient will have the combination of the chemotherapy. We call them as the CHOP therapy. And this is going to give at least 85% of cure rate. Okay, so that is 85%. So what is the CHOP therapy? This is going to include the following. So the drugs that are involved here includes the cyclophosphamide, which is an alkylating agent that will damage the DNA of the cancer cells. And so the cancer cells will no longer be able to grow and replicate. And then we also have the hydroxydunomycin or the doxorubicin. This is a medication that is going to insert itself between the DNA strands, and it will also block the topoisomerase 2, which is an essential component of the cancer cell DNA. And so it will not be able to replicate, and it will no longer be able to repair once this medication is taken. All right. Again, this is going to block the topoisomerase 2, and also it will insert into the DNA strands of the cancer cell. Now, the number 3 here is the oncovin, or popularly known as the vincristine, which is a vinca alkaloid. This is going to disrupt the formation of the mitotic spindle during the cell division of the cancer cell. And of course, this will lead to the cancer cell death. oncovin, vincristine. So we have the last one, prednisone, which is an immunosuppressant medication. It's a steroid, right? As we know, this is going to reduce the inflammation. It will reduce the inflammation and will also suppress immune response. So the prednisone here has a very unique role in the treatment of the non-Hodgkin's lymphoma, being used as an anti-cancer agent. And the exact mechanism here with the prednisone is not quite understood yet. I mean, not fully understood, but it has a unique role in the treatment of the non-Hodgkin's lymphoma. Now, if you're going to ask how many cycles will be done for this patient with a non-Hodgkin's lymphoma, well, it will also depend on so many factors. Maybe the type of the non-Hodgkin's and also the stage of the non-Hodgkin's lymphoma and also the patient's overall health. So we don't have definitive number of cycles known yet. It is going to be varied. Now, the CHOP therapy, basically those 4 medications, will also be combined with other treatments, maybe with the use of maybe the monoclonal antibodies. I don't know if you have heard of the rituximab R, actually rituximab. So this is rituximab. This is a monoclonal antibody that can be used together with the CHOP. And so probably you're going to see this kind of treatment, R-CHOP, which is basically the combination of the 5 medications. So this will enhance more effectiveness into the treatment. Okay. And the R-CHOP is going to be, again, the mainstay in the treatment of the non-Hodgkin's lymphoma. And here we need to know about the different side effects, guys. Hang on a second. Let me erase this. Side effects of the CHOP therapy. What are those known side effects? Well, we already know about the very common ones, the nausea and vomiting. Don't forget about that. There's also going to be alopecia, hair loss, which is common. And the most dangerous one, which is the bone marrow suppression, where all the blood counts will be greatly affected. Again, I'm talking about the anemia, severe anemia, neutropenia, and thrombocytopenia. The platelet counts will be critically low. There's also a drop in the white blood cells, the neutrophil counts. They're going to be prone to getting those infections, and the patient's red blood cell count will be also decreased. So I'm not going to repeat all those manifestations. You already know those, right? Anemia, thrombocytopenia. They're going to be prone to bleeding. Their skin color is really pale. They're overly fatigued, right? Exhausted easily, even with so many, even with slight movements, or let's say they're not going to be able to tolerate those same activities that they were able to do in the past. And so there is decreased tolerance in those ADLs. Now, we're going to compare the differences between the NHL and also the Hodgkin's lymphoma. So just kind of wrap it up. So let's do that real quick. So let's talk about the two. So let me put a white screen over here. Let me give this a try. I haven't done this before. So I hope that you can still see the screen. It's all white this time. So we're going to compare between the Hutkin lymphoma versus the NHL. Now, the Hutkin lymphoma basically is characterized by what? The reed Sternberg cells. Remember about the owl's eye description about the cell? It has so many nucleus, okay? So that's another hallmark description about the Hutkin lymphoma. Now, talking about the age group here, about the NHL rather. So what do you think about the classification or the characteristic of the cells in the HL or the non-Hutkin lymphoma rather? Well, there are so many variety of lymphocyte types, varied types. Okay, what about the age? Remember about the young adult and the older adults? Okay, so the occurrence of the Hutkin lymphoma can attack those two main age groups, the young adults. It will peak into the young adults and also the older adults. However, with the NHL, it can occur in a variety of all age groups. All age groups. Now, if we were talking about the node involvement, what do you think would be the differences here between the two? With the Hutkin lymphoma, the lymph node involvement will progress in a much more orderly manner. The progression of lymph node is much more orderly, meaning it doesn't spread right away into very distant sites, right? But it can attack the more those areas that are near to the origin, the site of origin. However, in the NHL, the node involvement can multiply so many lymph nodes unpredictably. Unpredictable involvement of other lymph nodes. It can spread to other lymph nodes right away. Unpredictable. Now, talking about the prognosis here, about the Hutkin lymphoma, it is known that the Hutkin lymphoma has better diagnosis compared to the NHL and is more responsive to the chemotherapy. Responsive to chemo compared to the NHL. So I'll just put here less responsive to chemo. All right. And of course, with the prognosis here, can vary between the two different types of cancer as well. So I guess this will help you with the differentiation between the two. Talking about the cell types, we have the Hutkin's lymphoma, which has that characteristic Reed-Steinberg cells, whereas the NHL, it is so varied. Whereas with age, we'll see that in the Hutkin's lymphoma, it can affect primarily the young adults and older adults. However, with the NHL, it can affect so many age groups. And then for the node involvement, the progression will be much more orderly. However, it will be unpredictable for the NHL. And with the treatment, Hutkin's lymphoma is much more responsive to the chemotherapy. All right. So I hope that kind of give you an idea about the differences between the two. Now let's talk about the first question this time. So are you ready, guys? First question. A 25-year-old female patient diagnosed with stage 2A Hutchin's disease. She presents with painless cervical lymphadenopathy, low-grade fever, and significant weight loss. Okay, so that's actually 2B. Just want to check. So the scenario is saying a 25-year-old female patient diagnosed with stage 2B Hutchin's disease. She presents with painless cervical lymphadenopathy, low-grade fever, and significant weight loss. Recent PET scans confirmed localized involvement of the cervical lymph nodes. She is currently receiving external beam radiation therapy and is anxious about the potential for secondary malignancies due to her treatment. The question is, what is a priority nursing intervention to address her concern? All right. Our patient has 2B, stage 2B Hutchin's disease, has low-grade fever, significant weight loss, and the patient has localized involvement of the cervical lymph nodes, currently receiving radiation therapy, and very anxious about the potential to developing secondary malignancies. So what is your priority nursing intervention to address this patient's concerns? We are seeing an answer of D from Mickey and Nini. Welcome to the class. This is the first time I've seen your names, or maybe you've been in the class for quite a long time, but this is the first time that you've answered the question in the chat box. So welcome. All righty. So what would be your priority nursing intervention to address the concern? So take a look here in our question. She is currently receiving external beam radiation, anxious about the potential for secondary malignancies. Remember about the treatment that we talked about earlier with the chemo, that there is a possibility that our patient will be developing secondary cancers, or a different form of cancer. Okay, so the information here about the chemotherapy is hidden in this scenario, but when we are talking about 2B Hutchin's, they're already in a chemotherapy here. So what would be your priority nursing intervention? So let's filter these options. Let's start with letter A. What do you think about letter A? Monitoring for skin reactions. Well, we know that it is important in managing the immediate side effects, right, of the radiation. So effects of radiation treatment. This is also important, okay? But again, it will not address the concern. Does not address the concern. So we are going to eliminate that one. Monitor skin reactions. This is not the problem that the patient is presenting. So we are going to X that out. What about letter B? Educate about potential long-term effects. What do you think about this item? Long-term effects. Well, when we are talking about the 2B involvement, this is going to affect at least 2 or more lymph nodes. Okay, so let's talk first about the 2B. 2B Hutchin's lymphoma. So what does that mean? There are going to be 2 or more lymph nodes affected. 2 or more lymph nodes, but they are confined to the same side of the diaphragm. Confined to the same side of the diaphragm. And the patient here has already manifested the fever. Did we have fever information here? We don't have a fever, but oh yeah, we have a low-grade fever. So when we are talking about 2B, the person will be expected to develop fever, and there's also going to be weight loss, right? And this is what we are referring to as the B: fever, weight loss, and the person will also have drench of sweat during the nighttime when they are sleeping. Night sweats. So these are the expected symptoms that will also worsen as the disease process is going to progress. Now, the correct answer here, or basically the rationale for this answer, educate about the potential long-term effects. Well, the therapy in this patient will actually include the development of secondary cancers. Okay, and we really want to educate them about the understanding on the importance of a compliance with the therapy and also the follow-up care. So this is basically what will address the patient's worry. Educate about long-term effects. Okay, the patient has already said something about being worried about the long-term effects. What did it say that? She is currently receiving to address her concern, malignancies. So this is basically what we are gonna teach her. Okay, if we had answered letter C, provide emotional support, what do you think about that intervention? Provide emotional support. It is also important, but it should accompany about the potential risk as well. Okay, it will not take higher priority compared to letter B. What about letter D? Encourage regular follow-ups. This is also an important teaching, but again, this should follow after the patient understands the long-term effects of her treatment. Should occur once the patient understood the long-term effects of the treatment. So the rest are actually going to follow once the patient has been given the correct explanation. Okay, understood the long-term effects of the disease. Alrighty, that's question number 1. Who got the correct answer here? I hope we have many. So there's only a few. Joyce, Mary, we also have Marie Fleur. Okay, so that's the correct answer. Educate about the potential long-term effects. Let's talk about number 2. A 30-year-old male diagnosed with stage 2 Hutchin's disease presents with persistent night sweats, fever, and 10% body weight loss over the past 6 months. His complete blood count shows mild anemia and lymphopenia. He is currently undergoing the ABVD chemotherapy and has been reporting increased fatigue and night sweats in the past week. What is the priority nursing intervention for this patient? Is it monitor fluid balance? Is it assess for infection? Are we going to provide comfort measures? Or is the priority to monitor the nutritional status? What is your priority nursing intervention for this patient that has what? Anemia, lymphopenia, increasing fatigue, night sweats. So what do you think about this patient condition? And there's more manifestation: night sweats, fever, 10% body weight loss over the past 6 months. What would be your priority nursing intervention? Okay. We are seeing C's, B, B. Okay. Our patient is in stage 2B Hutchin's disease. Well, let's take a look on option number letter A, monitor fluid balance. Do you think this is going to be the priority nursing intervention? We know that monitoring fluid balance is actually a good intervention, but it is a secondary intervention. Secondary intervention, not a primary. Okay. We're going to look for a life-threatening complication here. This is the goal of this test question. Are you able to identify a much more life-threatening condition? So what would be that problem? Okay. Let's take a look on letter B. Assess for infection. And as we know, there's already manifestation of night sweats, fever, weight loss. Those signs are constitutional manifestations of an infection. Okay, so we are going to do letter B, assess for infection. Okay, these are common manifestation of, again, infection. Don't forget that. The severe night sweats, the unexplained weight loss, the fever are actually symptoms of underlying infection. Symptoms of underlying infection. So we need to investigate further about this. And this is a life-threatening complication because we know that a patient is immunocompromised, right? Now, what about letter C? Provide comfort measures. Yeah, it's also important, but does it take higher priority compared to the assessment of infection? No. It will be, let's say, secondary or tertiary, or maybe a third priority, okay? What about letter D? Monitor nutritional status. It is also important for the overall health of our patient, but it's not going to be an immediate priority. Not immediate priority. Okay. And recall, guys, that our patient is currently undergoing ABVD chemotherapy. Do you remember about the complication, which is the bone marrow suppression? Don't forget that. That is a very common side effect in the chemotherapy. Bone marrow suppression, wherein the patient will be at risk to getting infections. Other than that, they're also going to develop the anemia, and the other one is the development of thrombocytopenia. Do not forget that, guys. All right? Infection, infection, infection. Congratulations to those who got the correct answer. Let's move on to number 3. Question number 3. A 45-year-old female with stage 3 Hutchin's disease, currently on her 3rd cycle of ABVD chemotherapy. She reports nausea, fatigue, and occasional tingling in her fingers. Her latest CBC reveals neutropenia. What is the priority nursing intervention to manage the common side effects of this regimen? Is it A, administer antiemetics, B, monitor for signs of infection, C, encourage high fiber diet, D, assess for peripheral neuropathy? The question states, a 45-year-old female with stage 3 Hutchin's disease, currently on her 3rd cycle of ABVD chemo. She reports nausea, fatigue, occasional tingling in her fingers. Her latest CBC reveals neutropenia. What is the priority nursing intervention to manage the common side effects of this regimen? Is it A, is it B, is it C, or D? Your answers, please. So our patient is in her 3rd cycle of ABVD. Nausea, fatigue, neutropenia, priority nursing intervention. You've already seen the clue from the previous test item, right? Our priority intervention here is to monitor signs of infection. This is life-threatening, guys. The neutropenia, it's already displayed in the scenario. This is life-threatening. The reason, again, because of the myelosuppression caused by the ABVD. They are prone to developing the infection because of the suppression of their neutrophil count, the white blood cell count. And of course, this is going to be a critical phase for this patient. Their they can develop severe complications at this point. Remember about that patient that has neutropenic fever? Yeah. Our patient needs to be on reverse isolation. We want to make sure that our patient is on a very protected diet. We just can't allow anybody to come in, see the patient, because they might be carriers of some infection. Let's say, for example, maybe they had a recent immunization of a live virus. Yeah, we're not going to allow just anybody to visit this patient, especially in the hospital. If you had answered letter A, administer antiemetics. I know chemotherapy can lead to the nausea and vomiting, but it is not as life-threatening compared to the infection. So we're going to have to prioritize letter B. What about letter C? Encourage high-fiber diet. We know that the common side effect of the chemotherapeutic agent is constipation. And part of our treatment or nursing care is to increase high fiber. But is this going to be as critical compared to letter B? No, it isn't. All right. So we can deal with this after we have dealt with the patient's possible infection. Now, letter D, assess for peripheral neuropathy. We know that peripheral neuropathy is another side effect of the chemotherapy, but this is not going to be the most critical intervention that we should be doing this time. We need to take care of the patient's infection first. All right. So this is on letter B. Don't forget that, guys. Always think about the myelosuppression. This is huge. Myelosuppression. Now, talking about number 4 at this time, a 50-year-old male diagnosed with stage 3 Hutchin's disease, currently undergoing chemo. He reports severe itching that worsens at night, significantly affecting his sleep. Liver function tests are within normal limits, and his eosinophil count is elevated. Which intervention should the nurse implement to provide relief? Is it A, administer antihistamines, B, apply moisturizing lotion, C, encourage a cool bath, D, monitor liver function tests? Take your pick, guys. So this is a case of a patient with stage 3 Hutchin's disease undergoing chemo. And now he is complaining of severe itching, not just mild, but severe itching that worsens at night. So it's affecting his sleep. Well, that sucks. That is really going to be bad for those people that are already insomniac, like this one. Oh my gosh, that is bad. We have an answer of A from Jet, also Marie Floor. Okay, we have Mary answering A as well. So I really want you to pay attention into the scenario. Take a look into the main concern by this patient. We are talking about severe itching. Okay, so we need to deal with that itching. What could possibly give much more of a relief? Okay, what could appropriately treat the severe itching in this patient? Okay, so this is what we are looking for in this test question. If you had answered letter D, which is monitor liver function tests, will it really help the pruritus? Will it directly address? No, it doesn't. Does not address. Does not address pruritus. We know that liver function test monitoring is also important, right? In chemotherapy, yeah. Good intervention, but does not address the severe pruritus. What about encourage a cool bath? Yeah, this is also important. It can soothe the skin temporarily. Temporary relief. Okay, but it doesn't really address the underlying cause. What about letter B? Apply moisturizing lotion. Yeah, it can be helpful in providing relief to the dry skin, but it will not be as effective as the administration of the antihistamine. So our correct answer here is the administration of antihistamines. These three are all wrong. They said the liver is normal. Yeah. Yep, that's true. Good catch, Lindy. Within normal limits. But again, guys, with the chemotherapy, there will be periodic testing of the liver function or the liver enzymes in order just to safeguard the patient when they are undergoing the chemotherapy. Okay. Maybe it was normal in the past week or 2 weeks. Maybe it can change in the following week. So it's really important that we still monitor. Okay. Yeah, when there is a problem in the liver, if this can cause some impairment, then it can also result to the bile salts in the skin, and this can complicate the problem as well. Okay. So this is a problem, the severe itching. What is really the cause of the itching? It's not about the impairment of the liver here, as it's being reflected that there's no problem in the liver function, but the main cause for the itching here, it's because the histamine is being released from the eosinophils. Okay, histamine release from the eosinophils. And that is the reason why our patient is having the severe itching. All right. So again, the pruritus that the patient is experiencing right now is caused by the release of the histamine from the eosinophils, and this is going to be properly treated with the use of the antihistamine medications. Okay. All righty. Let's move on to number 5, guys. I hope that you're starting to get into the groove right now. We are talking about cancer and chemotherapy. Not everyone is really liking chemotherapy. I mean, the pharmacology. It's nobody really enjoys talking about the oncology and this kind of stuff. So we will attack this monster today. We will try our very best to get some more understanding and insights, right? Number 5, a 35-year-old female with stage 4 Hutchin's disease presenting with a generalized lymphadenopathy and B symptoms, which are fever, night sweats, weight loss. She is scheduled for a biopsy of an axillary lymph node to assess disease progression. Her recent CBC shows anemia and thrombocytopenia. What should the nurse prioritize in the pre-op period? Is it A, explain the procedure, B, obtain informed consent, C, administer pre-op medications, D, ensure NPO status? What was that, Lindy? No, I don't. Can you please elaborate? Okay, so our patient here has stage 4 Hutchin's disease with generalized lymphadenopathy and B symptoms. So the patient this time is scheduled for the biopsy of the axillary lymph node to assess the disease progression. So what should the nurse prioritize in the pre-op period before the biopsy of the axillary lymph node? Is it explain procedure, or is it obtaining informed consent, or C, administer pre-op meds, or D, ensure NPO status? I'm seeing D, B, 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 B. Okay. B is good. This is the primary action that the nurse should be doing at this point. The priority task. Okay? This is very important. Obtaining informed consent. We're not just talking about simply grabbing that paperwork and have them sign the paperwork. No, it's just not talking about that. It's actually involving a conversation between the nurse and the patient. Ask them, do they understand the procedure? Do they know the risk and the benefits? Did they get a proper explanation from the surgeon? If the patient will say, no, I did not get a clear description of what this procedure is, I did not get any explanation about the risk and the benefits, then yes, this patient will definitely need clarification. You should not be getting that consent for this patient if they did not understand the entirety of the medical provider's conversation, right? This is very important, okay? So, not just about signing the paperwork. You really need to assess their level of understanding. Did they get enough explanation? This is what we call as informed consent. Do they know the risks involved, the adverse effects, the possible debilitating outcomes of this procedure? Do they know about that? Because if they don't, then they did not get full explanation from the medical provider. All right? It's just not about signing the paperwork. And so here, this is a legal document that is required. It is an ethical requirement before we are going to proceed with sending this patient to that invasive procedure. So again, we want to make sure that the patient is fully aware, okay, of the procedure. Again, the risks, the benefits, and alternatives. So these are things that we need to talk with the patient when we are getting that informed consent. All right, so this is our primary responsibility. What about explaining the procedure? Well, primarily the surgeon will be doing the explanation, okay? We can also explain partly though, but it's not our primary action, guys. Our primary action is really to obtain that informed consent once we assess that the patient has been fully aware about all the different aspects of the preliminaries, okay? Yeah, they're supposed to explain the procedure clearly. They should have asked all those doubts, the questions that they might have in mind. So this is supposed to happen. Now, so A is not going to be the sole priority. So we are eliminating that one. C, administer pre-op medications. Well, pre-op medication administration basically means that the patient has already been sent or is already in the holding area, right? So everything is assumed to have, oh, maybe the patient has already been given the explanation. So yeah, but administering pre-op medication, this is going to take place after the patient has received the explanation and also has signed the informed consent. So this is going to take place after informed consent has been obtained. All right. So we're going to eliminate letter C as well. What about letter D? Ensure NPO status. Yes, we can do this as soon as the patient has already signed the consent. All right. It will follow after signing of consent. Because in the consent, it will state there that they're going to be compliant with the preparation, including being placed in NPO, right? That will include there in the consent. It's just not about the, what do you call this? The surgical procedure itself, but it will be part of the consent as well. So our answer here is letter B. That is very huge, guys. Do not forget about that. Number 6, a 28-year-old male with stage 2B Hutchin's disease is worried about infertility due to the ABVD chemo treatment plan. He expresses concern about the potential impact of chemo as he plans to have children in the future. What should the nurse discuss with him? Is it A, the effects of chemotherapy on fertility? B, options for preserving fertility? C, the likelihood of regaining fertility post-treatment? Or D, the impact of radiation therapy on reproductive organs? What would be? What would the nurse discuss with him this time? Take note of the statement. He expresses concern about the potential impact of chemotherapy as he plans to have children in the future. What would be that discussion gonna entail? Well, let's go through the options here. What about letter A? The effects of chemo on fertility. This is important, guys. This is important. We need to discuss about the effects of the chemo into the reproductive function. This is a good part of the discussion, the effects. However, when we are talking about the patient's concern about having children in the future, what the conversation should have is about preserving the fertility. So we need to discuss about what the options for, let's say, preserving fertility. So we need to discuss this more. Options. Maybe we're gonna include here sperm banking. That's one. Very important. Right? So the person here, the patient, will be given much more of an informed decision before they can start treatment. And so they can get much more of proactive steps in order to preserve his fertility. So this is why letter B is the correct answer. Options for preserving fertility. This will precede the explanation about the chemotherapy, effects of chemotherapy on their fertility. Yeah, they already know that, right? He is already worried about it. He is already concerned about the potential side effect or the potential impact. So he is already aware about that. And so our conversation should focus on preserving fertility by this option, preserving, or let's say sperm banking. What about letter C? The likelihood of regaining fertility after the treatment. It is also important, guys, but the patient needs to know how to preserve, the fertility preservation process. This is the main, the need for this test item. Regaining fertility post-treatment is not going to be as high priority compared to discussing the kind of option that they can have. All right, so we are going to eliminate that. What about letter D? The impact of radiation therapy on reproductive organs. It is also important to discuss this aspect, but the preservation strategies would be much more of a high priority here, guys. So we are going to select letter B. Okay. So basically what we're looking here in this test question is what could address the patient's concern about not having children because of the impact of the chemo. So we will give him the information that, hey, we have an alternative for you in case you will get infertile. Okay, so we have this possibility in the future that if you're going to be infertile, you will still be able to have children in the future. Okay, did you get that? So our answer here is letter B. Moving on to number 7. A 60-year-old female with stage 3 Hutchin's disease undergoing external beam radiation therapy. She reports severe fatigue, difficulty performing daily activities, and insomnia. Laboratory tests show mild anemia and normal electrolyte levels. What should the nurse recommend? Okay, let me reread. A 60-year-old female with stage 3 Hutchin's disease undergoing external beam radiation therapy. She reports severe fatigue, difficulty performing daily activities, and insomnia. Lab tests show mild anemia and normal electrolyte levels. What should the nurse recommend? Is it A, increasing fluid intake, B, taking short naps, C, limiting activity, D, eating a high-calorie diet? Take your pick. Severe fatigue, difficulty performing daily activities, insomnia, and the patient has known mild anemia, normal electrolyte levels. What do you think would you recommend that can help best this patient? The patient already has difficulty performing daily activities and severe fatigue. So the patient now is probably just exhausted. What do you think of a person that is already exhausted? Do you think that they're still going to do a lot of activities? I doubt. I doubt. Right? So, severe fatigue, difficulty performing daily activities, and insomnia. What do you think can help manage their severe fatigue? Okay, let's take a look. I'm seeing a lot of letter C's this time. There's one B, there's one D. Let's take a look. Letter A. Increasing fluid intake. Well, it is important to maintain hydration of our patient, but will not address fatigue. Important. Does not address fatigue. Okay, hydration is good, but it will not resolve the issue. What about letter D? Let me try answering first the extremes here. Eating high-calorie diet. What do you think about that? High-calorie diet is very important. But do you think that this can really manage the excessive fatigue? The patient is getting external beam radiation therapy, guys. With stage 3, it's not going to be sufficient. Not sufficient. Or it will not really address the fatigue. Not address the fatigue. Guys, we know that the patient already has insomnia, right? Sleeplessness. That's your clue right there. Do you see what I'm looking at right now? Difficulty performing daily activities. There's also insomnia. What do you think can help decrease the fatigue? All right. Let's take a look at letter C, limiting activity. Yeah, it's also important to limit their activity. We know that they're already exhausted, right? But if we are going to really limit their activity, we don't know what limitation. This is kind of a vague limitation. Do we have a specific limitation stated in letter C? No, it's not very clear as to what limitation we're going to give the patient. So it's not going to be healthy as well if we're just going to limit their activity, as we know that at some point they need to have some form of activity in order to prevent other complications from setting in. Okay, but take note about the scenario. The patient already has insomnia, over fatigue, difficulty performing activities. So we don't have any best option here other than taking short naps. Those power naps are actually going to be helpful in our patient in the radiation treatment and also in chemotherapy, guys. This is very important. It will help manage the fatigue without significantly disrupting the patient's daily routine. Okay, I'm not talking about a nap that could take like an hour or 2 hours. A nap could be just about 15-20 minutes, maybe several times in a day, right? It will enable the patient to conserve their energy. Okay, conservation of energy is key. Energy. It can worsen the insomnia for some. Yeah, because I've had insomnia for 19 years. Trust me, I've had that. I've worked night shift for 15 years. And so I've dealt with the insomnia with so many different modalities. The naps will not really help, but will it help the fatigue? Yes, it can. Yeah. It will not resolve the insomnia, but what we are dealing here is about the fatigue. Okay. Okay. Our response here is about the severe fatigability and her intolerance to dealing with the daily activities. Okay, so this is gonna this will give a much heavier weight compared to the insomnia. It will not treat the insomnia. However, it will help with the severe fatigue. At night, she will suffer more insomnia. That's true. That is true. But again, how are we going to do with this patient? We really need to choose the lesser evil this time, right? Which is basically to address the severe fatigue, right? Yeah, I know that there in an ideal setting, we're going to have to address everything, right? But in this specific scenario, we're going to have to select what needs to be dealt with and what can be resolved easier. Is it a severe fatigue that can be resolved with frequent naps? Or are we going to resolve the insomnia? And we don't have really, do you have interventions here that can resolve the insomnia? We don't. So we're going to look for those alternatives. How is one having insomnia have sleep? Well, I'm talking about, when we're talking about insomnia, most often we will consider insomnia that they cannot really sleep during the normal nighttime, right? Right? So when we are talking insomnia, the normal sleep pattern, usually it will be, it's actually pertaining to the sleep during the nighttime. Okay? Sleep during the nighttime. People that have insomnia can sleep during the daytime, but they will have difficulty taking or getting their sleep during the night. Taking a nap is sleep. Yeah, it is a form of sleep. Yeah. And again, you can debate this all day long. Our goal here is really to diminish the severe fatigue of our patient. This is really the main concern here in our question. It's not really about the insomnia, guys. Yeah, it isn't. So I just want to clear things here. We have so many issues that we should be addressing, but looking into the issues, we need to address the severe fatigue that can be addressed by taking short naps. You cannot address any of the insomnia here just by high calorie diet, limiting activity. We got to do something that can be fixed in this situation. Taking short naps. All right, enough with this. Let's move forward with number 8. A 40-year-old male with stage 3B Hutchin's disease, currently on his 4th cycle of ABVD chemo. He reports easy bruising and petechiae. What side effect should the nurse closely monitor? Is it A, hypertension, B, neuropathy, C, thrombocytopenia, and D, renal failure? Just cause she has fatigue. If not, we will keep her awake just so she sleeps better at night. Yeah, that is another alternative, virtuous lady. Um, yeah, we can do that alternative as well. In a very ideal setting, we can do that. Yeah. Okay. We have 3B Hutchins, fourth cycle, bruising, petechiae. These are very important clues to our question. What side effect? Good, very good. Everyone got the correct answer, which is thrombocytopenia. Remember about the myelosuppression? It can also decrease platelet count. Don't forget that. That is a correct answer, guys. Thrombocytopenia. So we should monitor the patient for low platelet count because of the known bruising and petechiae. There's not such thing as hypertension as a, what do you call this? It's not really a typical side effect to the chemotherapeutic agents or the ABVD therapy. So we're going to eliminate this one. Not typical side effect. We are eliminating that. What about neuropathy? It can also occur, right? It can alter the nerve function. So we need to observe any tingling sensation, absence, or maybe numbness. That is also important. But as we are looking into the bruising and petechiae, this is much more critical. Our patient possibly can bleed out. So we are going to put this in the back burner. What about letter D, renal failure? It is not a common side effect of ABVD. Complication, I should say, not a common complication of ABVD. So we have to choose the thrombocytopenia. It's because there is myelosuppression in the chemotherapy. All right, let's pick this one. Now, moving on to the next question, number 9. 54. Oh, before we go to do that, I'm reminding everyone that we are offering the NCLEX course at our website, Stancoast, NCLEXcoaching.com. So kindly check the description box below. We have the link for you to look at. And so you can get some more information about our offering. So please drop by and check the link below so you can check out our offerings. All right, let's move forward to number 9. A 55-year-old female with stage 4 Hutchin's disease receiving ABVD chemo. She presents with severe nausea and vomiting. Her current medications include ondansetron as needed. What is the priority nursing intervention? Is it A, administer antiemetics as prescribed, B, encourage small frequent meals, C, provide oral care, and D, monitor electrolyte levels? Your answer, please. Receiving ABVD chemo with severe nausea and vomiting. Her current medications include ondansetron as needed. This topic wasn't my best while at school. It's more fun now. Thank you. Well, thank you, virtuous lady, who's in Houston, Texas. I'm in Houston. Oh, welcome, guys. So we have answers: encourage small frequent meals, and also A, administer antiemetics as prescribed. A and B. So we are split in between the A and B. Are you sure, guys? Chemotherapy. Chemotherapy. I haven't heard of any patient that had chemotherapy that never complained about nausea and vomiting. Everyone complained about it, no matter what. And so, what would be the best nursing intervention that we can offer to this patient in order to treat or prevent the nausea and the vomiting? I know these are all good interventions, guys. Yeah, if I have to be the nurse in this situation, I will pick everything, but we are tasked in this situation about priority nursing intervention. I would do everything. Everything looks good to me, but if we are going to choose the priority nursing action in order to prevent the occurrence of nausea, we are going to select letter A. Ondansetron is anti-emetic medication. Have you heard of ondansetron, guys? Known as the Zofran. Are you familiar with the name Zofran instead? Have you heard of the ODT, orally disintegrating tablet? Have you heard about this? Orally disintegrating tablet. Yeah? Okay, so in order for us to manage their nausea and vomiting, we are going to do letter A, administer antiemetic rather, as prescribed as the most immediate and effective intervention to control nausea. Severe. It said severe, guys. Severe nausea and vomiting. It will also improve their comfort. Okay, so we will be able to prevent more complications if we are treating them upon schedule. Okay, some of these patients will actually be getting routine doses of Zofran. I'm talking about chemo patients. They will be getting this in order to prevent the nausea and the vomiting. Before it can even set in, we're already preventing it. All right? So don't forget about the Zofran, which is an antiemetic medication. And if you've forgotten about the Zofran drug class, this is what we call as the what? The 5-HT3 receptor antagonist. And in my experience as an RN in the bedside for 14 years in the bedside as a neuro and also medical surgical nurse, partly critical care. This is a first-line antiemetic medications. It has milder side effects compared to other antiemetic drugs. Okay, when we are talking about chemotherapy, our patient really need to have this treatment, antiemetic medication. This will prevent any more complications such as fluid electrolyte imbalances. Okay, so what is really the goal here for the antiemetic therapy? Prevents emesis and also preventing fluid and electrolyte imbalances. Because if we are not going to control the emesis, they're probably gonna be nonstop puking every now and then, and they're gonna end up with metabolic alkalosis, right? Losing a lot of hydrochloric acids, and this is not what we want in this patient. And they definitely need to get this way ahead of time. I mean, it should be scheduled in order to prevent the nausea to occur. Now, as we're gonna talk about the Zofran, what are the common side effects here? Common. Do you still remember the side effects of the Zofran? If I may ask, what are the side effects of Zofran ondansetron? For some people, they probably would complain about the headache, but rarely I've encountered a patient complaining about the headache, but this is something that you need to also assess in your patient. Mild headache. It can happen, but rarely. Never heard of anyone really complaining about it. There's also some irregular bowel pattern. They can probably lead to constipation or diarrhea. So either diarrhea or constipation. Let me just write it out before I'll get you confused here. Diarrhea, constipation. Diarrhea and constipation, either And then they're also going to have some fatigue. And of course, the onset of the manifestations here, or the side effects, will be dependent on how often they are getting the medication, right? They also will complain of dizziness. No, it isn't anticholinergic. It's a different drug class, James. It is what we call as the 5-HT3 receptor antagonist. Okay. The patient will also complain some visual disturbances that is going to be temporary. They're also going to complain a little bit of mouth dryness. Okay. They said in the textbook, it said that it can cause hypotension, low blood pressure, but with the amount of years that I have worked with so many patients, including the cancer patients, I've rarely encountered anyone having hypotension. Maybe in some other patients, but rarely I've encountered patient having hypotension. But again, we're including this in our list of side effects. Okay. Blurred vision. Yes, that's another issue with the ondansetron. It can cause temporary blurring. There's also a possibility of tachycardia. And so these are the things that we are going to expect as side effects. But again, I've never heard so much of these side effects with the patients that I've treated with the ondansetron. In my experience, what we have in the hospital, I'm not telling you that you should follow this, but in the hospital that I worked previously for 10 years, usually what we have in our antiemetic PRNs, what we usually have as our first line is actually ondansetron. And then we have the Reglan. And then lastly, we have the Phenergan, which is the promethazine. Okay. These two other medications are actually known to cause some kind of like sedative effect, especially the Phenergan, and also some CNS disturbances, Phenergan and Reglan. And so the reason that the ondansetron was going to be the mildest form, or really not really the mildest, but the primary antiemetic, it's because of the mild side effects that it can cause to a patient. And yeah, I believe that. I believe this thing because most of the patients that I've dealt with, they don't usually have those known side effects listed here, which is kind of ironic. But yeah, I'm just letting you know, guys. I don't know what other hospitals are doing, but so far this has been known to be quite safe and effective for the patients that we've had. And so if they're not responding to the Zofran or ondansetron, then we're going to have to go to the step 2, Reglan, and then followed by the Phenergan. But guys, in cancer therapy, the Ativan was actually the strongest antiemetic medication. Do you know that? Ativan, lorazepam, is also an effective antiemetic medication. All right, so add that in your library of antiemetic medications for those chemotherapy patients. Now let's continue here. Encourage small frequent meals. What do you think about this one? Encourage small frequent meals. Is it a good intervention? Yes, it is. But will it control the nausea effectively compared to the other answer, which is the antiemetic medication? No, it will not. It will be helpful to some degree, but not really as effective compared to the antiemetic. Providing oral care is also important for overall comfort, but it's not gonna prevent the nausea and the vomiting. And then we have the monitoring of electrolyte levels, another important intervention. Possibly there is an imbalance that we don't know, so we need to monitor. But will it prevent the occurrence of nausea and vomiting at this point? It doesn't. It will not resolve the root cause. So we are also eliminating that one. Okay. Let's move on to the next. Yeah. Are you pertaining to the Ativan Milrose for the as an antiemetic medication? Yeah, look it up in the literature about the involvement or the importance or the significance of the use of Ativan or lorazepam in preventing nausea. It's actually one of the mainstays in treating intractable nausea and vomiting in cancer therapy. Okay. Number 10, a 48-year-old male with stage 2 Hutchin's disease on his 6th cycle of ABVD chemo. He reports tingling, numbness, and weakness in his hands and feet. Recent neurological assessment confirms peripheral neuropathy. What intervention should the nurse prioritize? Is it A, administer pain med, B, assess for safety hazards, C, encourage physical therapy, D, provide warm compress? Our patient, stage 2 Hutchin disease, 6th cycle of ABVD chemo, has tingling, numbness, weakness in his hands and feet. Neurological assessment recently confirms peripheral neuropathy. What intervention should the nurse prioritize? Are you going to do A, administer pain medication? Let's take a look into the statement here or the scenario. Will the pain medication administration address the presenting manifestation? No. Really? Are you sure? Okay, let's talk about this, guys. What are these things? Tingling sensation. Have you talked in depth with a patient that has peripheral neuropathy? Have you really talked to them about the antiemetic can cause extrapyramidal effects? Yes, that's correct. And so many others. Thank you for the information, Ideola. So what is this peripheral neuropathy? Well, basically, this is a very uncomfortable sensation by this patient. They can range from being numb. They probably would feel those tingling pins and needles into their toes, the soles of their feet, their fingertips. This is very uncomfortable, guys. And so some of these patients would require pain medications as well, okay? I'm not talking about the high-powered opioid medications. Maybe to some degree they might need that if the pain becomes so severe, but eventually they need some form of pain medication to control the peripheral neuropathy. The numbness, tingling sensation, the pins and needles. Yeah, this can keep them awake at night. Have you heard of them being insomniac because of the pins and needles sensation? This is bothersome, guys, and this is going to be chronic. Let's say, for example, those patients that may have diabetes mellitus, but here we're talking about a chemo patient with the side effects, right, with a peripheral neuropathy, which can become permanent. Now, yeah, it is important that we can administer them the pain medication, but there is much more weight into the other choice. So let's hang tight here. Let's take a look on letter D, provide warm compress. Do you think that this will keep our patient safe? Okay, so what is really a problem here? There is a safety issue. Take a look into the data. There is numbness, weakness in the hands and feet. Patient is a fall risk this time. Okay? They are at fall risk this time because of the peripheral neuropathy plus the weakness of the feet and also the hands. Probably this patient also has unstable gait. We don't know. We don't have that information. What do you think could possibly happen in this patient if we don't prioritize our nursing intervention? This doesn't do it. This doesn't really maintain the safety of our patient. It can treat the pain, but will it promote safety to our patient? What about this one? Encourage physical therapy. It is helpful, guys. Physical therapy will be important to our patient. But this is going to be beneficial for long-term management. Beneficial for long-term management. It can be, but not the immediate priority this time. So we have letter B as our best answer. Assess for safety hazards. This is going to be our correct answer this time. Are you going to touch all areas of NCLEX like management of care, pharmacology, patient teaching, prioritization? I hope so. I will talk to my boss. Yeah, I'm not quite sure yet if I'll be the same person who will be doing the rest, but I don't know. Maybe. So that's a good idea. Let's proceed, guys. We are going to have to select again the letter B, which will prevent this issue. Okay, we have a safety issue going on in this scenario. The patient is a high fall risk because of an altered sensation in the extremities. The weakness is another one. So this would be our best answer. Safety, assess for the safety hazards. All right, I hope that you were capturing the explanation, guys. Now, number 10. Is it number 10? Oh, so this is basically number 11 then. Oh, that's a repetitive test question. So let me move forward with 11. A 35-year-old female with relapsed Hutchin's disease scheduled for an autologous stem cell transplant. Her pre-transplant evaluation includes high-dose chemo to ablate her bone marrow. What should the nurse prioritize in her care? A 35-year-old female with relapsed Hutchin's disease scheduled for an autologous stem cell transplant. Her pre-transplant evaluation includes high-dose chemo to ablate her bone marrow. What should the nurse prioritize in her care? Is it A, educate about the procedure, B, ensure a sterile environment, C, administer immunosuppressive therapy, D, monitor for graft versus host disease? Fortunately, this patient has a relapse of Hutchin's. And of course, now the plan is to do stem cell transplant, which is very promising. The patient has probably, has not really responded to the other treatments. So what do you think would be the priority? Okay. Is it educate about the procedure, ensure a sterile environment, administer immunosuppressive therapy, or D, monitor for graft versus host disease? Guys, stem cell transplant, this is a very strict procedure. We need to really observe, especially with the environment of the patient, we need to make sure that we are not going to allow any kind of a possible source of infection. And so we really need to be careful, especially with the making sure that our patient will not get any of the opportunistic infections. So what would be that? Okay. I almost gave the answer. Let's take a look on letter A. Educate about the procedure. Transplantation, stem cell. Letter A. Educate about the procedure. Well, it is also a priority. But will this be a higher priority to preventing infection? Okay, will this prevent Will this address the possibility of preventing infection? Not really. It's just going to give them a head knowledge, just information about the procedure, but will this prevent the infection? That is the question. It will not. So we are going to eliminate this one. Like I've said, with the bone marrow procedure, everything should be done in a very strict, sterile, or let's say a very sterile environment. So we don't have any answer here, but letter B. Ensure a sterile environment. No one can just go inside the patient's room, or especially during the procedure, without observing those sterile techniques. And so this is the correct answer. Our patient is higher risk to developing infections because of the what? Bone marrow suppression. They are easily going to get any opportunistic infection, so we have to ensure a sterile environment for this patient, okay? It is going to be easily compromised this time if we're not going to practice this strictly. And especially with a stem cell transplant, this is going to require a whole lot more of sterility procedure or sterile procedures. Now, taking a look into letter C right now, administer immunosuppressive therapy. Well, remember that the case already states includes high-dose chemotherapy to ablate the bone marrow. Okay, do we still need to, will this really place a higher priority? It's not really going to maintain the sterility. It's not going to, not addressing possibility of opportunistic infections. Okay, it's not going to address possibility of opportunistic infection. It's just part of the treatment, right? Like with the corresponding statement, it's not really addressing the prevention of the infection. What about letter D? Monitor for graft versus host disease. What is this? This is going to be a priority for those allogenic type of transplant. Appropriate for allogenic transplant, not autologous. Okay, so we are talking about, did we say autologous here? Yes, it's already in the situation. So this will not be applicable to letter D. Okay, we are talking about autologous stem cell transplant, its own stem cell. So this will not be appropriate. And we have found our correct answer, which is only letter B. Maintain sterile environment. Alrighty, number 12. A 70-year-old male with advanced stage Hutchin's disease receiving palliative care for pain management. He rates his pain as 8 out of 10 on a numeric pain scale. His current medication regimen includes morphine. His current medication regimen includes morphine for severe pain. What is the priority nursing intervention? Is it A, administer prescribed analgesics, B, provide emotional support, C, encourage relaxation techniques, and D, monitor vital signs? Okay. A 70-year-old male with advanced stage Hutchin's disease receiving palliative care. Pain management. He rates his pain as 8 out of 10 in a numeric pain scale. And pain medication includes morphine for severe pain. What is the priority? Are we going to do monitoring of vital signs, encouraging relaxation techniques, providing emotional support, administering prescribed analgesics? Looks like we have all of those as very necessary nursing actions, but our priority here is what? I'm seeing a lot of letter A, which is the correct answer. Our patient is in palliative care already. Palliative care, of course, the goal is to what? We're going to alleviate the discomfort of our patient. We want to make sure that they're getting pain control. And this is the only way of at least managing their discomfort. We really need to make sure that we are giving them the medication as scheduled or as needed. We need to at least get rid of that painful sensation that they have. They don't have anything else that they want but the pain control. Okay, so we want to make sure that we are addressing the most immediate problem, which is the pain. This is it. Letter B can be another nursing intervention, but it will not replace a higher priority, which is pain control. It is going to be a secondary action. The same thing with encouraging relaxation techniques, but again, not as effective as administration of the analgesics. Okay, and then monitoring of vital signs is also necessary, but will not really address the severe pain of our patient, which is 8 out of 10. Okay. All right. So that was an easy question. I hope that you're able to follow through with that rationale, making sure that we are promoting comfort of our patient. We are in palliative care. We are not curing the patient. Nothing is going to cure this patient, especially with an advanced stage Hutkin's disease. Nothing will. And so our goal here is to promote comfort for this patient. Yeah, this is quite a sad part of nursing. And I used to work in a nursing unit that deal with a lot of cancer patients. End stage life, it's quite depressing. It's just, yeah, it's sad. But I have to go through that kind of clinical experience. It kind of helped me to really understand dealing with this kind of patients in their, terminal end of life condition. So yeah, it's kind of sad, but again, that was kind of beneficial for me as well. So our goal here is to promote comfort, especially. Leading to number 13, a patient, a 52-year-old male with stage 3 Hutchin's disease, receiving a blood transfusion for a hemoglobin level of 7 grams per deciliter. During the transfusion, he reports chills, back pain, and discomfort. His pre-transfusion vital signs were stable. What is the priority nursing intervention? Is it A, stop the transfusion, B, administer antihistamines, C, monitor vital signs, and D, notify the physician? So our scenario states that the patient is getting blood product transfusion for hemoglobin of 7 grams per DL. Now the patient reports chills, back pain, discomfort. His pre-transfusion vital signs were stable. What is the priority nursing intervention? What do you think? Would that be notifying the physician? Would that be monitoring vital signs? Administer antihistamines? Or is it A, stop the transfusion? What do you think would be the highest, or what would be that option that plays highest priority here? What is the priority? We are seeing lots of A. Very good, nurses. You pass the test. We are going to stop the transfusion. That is the first and foremost action. Whenever you're going to deal with a blood transfusion, always stop the transfusion as soon as the patient manifests those back pain. What else? Chills, discomfort. These are signs of the blood product reaction. Always do the stopping the transfusion. This is going to be your primary nursing action. Do not delay. Stop the transfusion, disconnect the tubing, and then make sure that we are going to have that normal saline, which is a fresh line of normal saline to run into our patient TKO for a possibility of administration of antihistamines. Okay, stop the transfusion. I know that these are all good nursing interventions, but again, we are being asked about the high priority here, which is basically the stopping of the transfusion. We can administer the antihistamines once we have confirmed that the patient indeed had the allergic reaction, okay? So we can possibly administer what? The diphenhydramine if confirmed, okay? But this can also take place, right? Once we have done these two, notifying the physician and also monitoring the vital signs. We need to have a baseline value of their blood pressure, their heart rate before we call the physician, right? We just don't want to call the physician without giving fresh set of vitals and also fresh assessment findings, right? Do not just call the medical provider without getting fresh set of vitals and other assessment, what do you call this? Clinical findings, all right? We need to have those in order that the physician can order accordingly the possible medications, right? So again, stop the transfusion is our priority. And then we're going to have to disconnect the tubing and keep that saline line open. And then we're going to have to do the monitoring of the vital signs, call the medical provider, and possibly we're going to get an order for an antihistamine once we have talked with the medical provider. So those are the possible sequence that we will be doing in a real scenario, okay? So these are signs of blood product reaction. It could be an allergic reaction. There's already chills. I didn't see any pruritus or any kind of like itching, but still, these are signs that the patient is reacting to the blood product. Immediately, we are going to disconnect, stop the transfusion. All right, this is going to be fun. We're going to talk about the blood transfusion in the next few days. All right, let's move on to number 14. A 34-year-old female with stage 2A Hutkin's disease undergoing ABVD chemo. She reports mild oral discomfort and is worried about developing severe mucositis. Her oral mucosa shows a slight redness but no ulcers. Well, that's good. Redness, no ulcers. What should the nurse recommend? Will that be A, use of soft bristled toothbrush, or B, rinse mouth with saline, C, avoid spicy foods, or D, apply lip balm? What would be your recommendation for this patient with slight redness but no ulcers? This is a side effect of your ABVD chemo. What do you think would be helpful? Let's take a look into letter D first. Apply lip balm. I know this can be helpful, guys, to relieve the dry lips, okay? And help with dry lips, but not directly address the mucositis, but does not address mucositis. When we're talking about mucositis, we're actually talking about the entire mouth, the oral cavity of our patient, which is very sore, okay? The lip balm would just address the dryness of the lips, but not the mouth, okay? What about avoiding spicy foods? Yeah, to some degree, it can be helpful. It will prevent irritation, but not really address mucositis. Prevents irritation, but not address the mucositis. does not address mucositis. Okay, we're gonna eliminate this one. What about letter A? Use of a soft bristled brush. Yeah, we can do that as well. It is important for oral hygiene because of that slight redness already. But will it soothe the patient's mucositis? Will not soothe. Mucositis. It can prevent breakdown. Yeah, that's true. But it will not prevent mucositis. I'm sorry, not prevent, but will not soothe the mucositis. All right, so we don't have anything else but rinsing the mouth with saline. Saline is such a underrated treatment, guys. Trust me, it is so underrated. There's so many benefits about the saline solution. Just rinsing, especially for those patients with mucositis. Some patients would not really believe you as a nurse, right? Because, yeah, that's just salt water. We have that at home. It doesn't resolve. Yes, it can. It actually have that healing property to draw the extra inflammation. It will reduce the inflammation, guys. Reduces inflammation in the mouth. Now, I really want to emphasize this, guys. Salt or sodium or salt, it is a hypertonic solution. Remember about a hypertonic solution in electrolytes, fluids, and electrolytes? It actually can shrink the cell or the tissue. So if there is such inflammation, swelling going on in the mouth, it can reduce the swelling. Simple as that. And the same thing when the patient will have some colds, if they're probably in the earlier stage of a respiratory infection, this actually can also help. The hypertonic saline gargle can also help decrease the inflammation. Trust me, it can. And I didn't believe my medical provider when I was sick because I was so focused into the pharmacology. I was so pissed that I did not get any medication prescription, but actually I tried the saline gargle and it actually helped really lessen the duration of my influenza. And trust me, it does work. It works. So encourage this, recommend this to your patient with the mucositis as a complication to ABVD therapy. Let's talk about number 15. A 70-year-old male with stage 2 Hutkin's disease receiving radiation therapy to the cervical lymph nodes. He reports pain and difficulty swallowing, leading to decreased food intake. Recent weight measurements show a 5-pound weight loss over 2 weeks. What should the nurse prioritize? Again, our patient has stage 2 Hutkin's disease, receiving radiation to the cervical lymph nodes, and now reporting pain, difficulty swallowing. Guys, this is common. Radiation therapy, whenever this is going to target that site, it can lead to problems like this, swallowing issue, leading to decreased food intake. Recent weight measurements show a 5-pound weight loss over 2 weeks. What should the nurse prioritize? Please don't get fooled, guys. Please don't get fooled. Please think. Please think. We already have information in our scenario. He reports pain, difficulty swallowing, leading to decreased food intake. Recent weight measurements show 5-pound weight loss over 2 weeks. What should the nurse prioritize? We already have so many information given in the scenario. So what would be that one? Is it assessing nutritional status? Is it encouraging soft foods? Monitor for weight loss, providing pain relief. And the scenario also mentioned about reports pain, difficulty swallowing. So what can help address the difficulty and the pain in swallowing? So we have what? Dysphagia, which is difficulty swallowing, and odynophagia, painful swallowing as a complication to, as complications to the radiation treatment. So let's take a look at letter D, pain relief. Do you think that this can address the issue in our scenario? Weight loss. 5-pound weight loss is very significant that already. 5-pound weight loss over 2 weeks. And that is quite the reason why the patient is really losing weight, because of the pain and difficulty swallowing. And it also stated here, leading to decreased food intake. Please pay attention to the scenario. Okay, that is our main problem. Nutritional intake. Because of the pain. So which of the following interventions can help our patient to properly ingest the food? That's basically what it is asking. All right. So letter D, provide pain relief. Do you think that this can address the patient's decreased intake? Pain relief. Yeah, it is also important, but do you think that this is going to deal with, will it be as immediate as adjusting the diet? No, it will not be as important. Okay? Important, but not as immediate as adjusting the diet. What about letter C? Monitor for weight loss. It is also necessary, but should follow the interventions to maintain the intake. Okay? Now let's take a look on assessing nutritional status. Between the A and B, are you quite torn between the A and B? Yeah, it is quite confusing. Where should I select? What should I select this time? So, as we know in the scenario, it is already given, right? It is already known in the scenario. So what we need to do here is to ensure that the patient can eat comfortably. This will address the main issue, which is basically difficulty swallowing. Encourage soft foods. This is going to help the patient. The assessment of the nutritional status has already been known in the scenario. We have that information given already. So our next step would be to go to the intervention phase, which is to basically encourage, advise the patient. Maybe puree food or ensure can address speech therapy for. Yes, these are all important nursing interventions as well. Puree food, yeah, soft foods are also going to include that one. And dietitian referral. Yeah, dietitian referral will be important here, so they can, or the speech therapy as well. They can coordinate, they can collaborate with us, especially, so we need to identify what could be the best, the possible alternatives, not just soft foods, but what others can be provided to our patient with this malnutrition, okay? Because they have problems swallowing, so they really need to carefully plan the best alternatives in order to address the malnutrition. There is already malnutrition. There is weight loss known in this scenario, okay? Thank you, Melrose. Very good suggestion. All right, I hope that you're able to get the rationale for this one. Again, our target here is to help the patient's poor nutritional intake. The assessment has already been known in this scenario. Let's move on to number 16. A 65-year-old female with advanced stage Hutchin's disease receiving palliative care for symptom management. She has experienced significant side effects from treatment and expresses a desire to stop. She has a supportive family who is involved in her care decisions. What should the nurse do? Is it A, respect her decision. B, encourage her to continue treatment. C, discuss alternative therapies. And D, involve her family in the discussion. So our patient is in advanced stage Hutchin's disease, receiving palliative care. Take note of the words palliative care for symptom management. She has experienced significant side effects from the treatment and expresses a desire to stop. So what do you think would be your intervention here? Are you going to do A, respect decision, or encourage her to continue treatment, or are you going to discuss alternative therapies, or D, involve family in the discussion? What would be your nursing action? Excuse me. Palliative care. Take note about palliative care, guys. Our goal here is more of comfort. Okay. So let's take a look into letter D first. Involve her family in the discussion. This is going to be a huge discussion, right? Especially if we're gonna involve the family. It's very important that they are going to be they are participating in the decision making. Yeah, this is also important. But again, our patient's wishes are the priority. Patient's wish. Remember about the autonomy. We have to respect that, guys. Okay? So we are eliminating letter D. It's very important that the family knows really the direction of the care. Hey, we are going to talk about that your patient, that your family member, your loved one has decided that she wants to discontinue the treatment. She doesn't want any more invasive procedures, no more curative medications, no more of those medications. Let's say the chemotherapeutic agents. This is what she said. Has experienced significant side effects from the treatment and expresses desire to stop. Right? So this is our patient's decision. She needs to maintain that autonomy. So the decision will really be based on the patient's decision. We're not gonna base our decision, or let's say the medical provider's decision, based on the family's decision. It's gonna be on the patient. What about letter C? What do you think about that one? Discussion of alternative therapies. Yeah, we can consider that, but should follow respecting her initial decision. Okay, so we are also going to eliminate that one. This is a possibility, but again, should follow after we respect her decision, which is letter A. If we're going to move forward with encouraging her to continue the treatment, what do you think about that? That's actually disregarding her autonomy. Okay, so we are eliminating this one. Disregards autonomy. She already desired that she doesn't want to do any more of the treatments because of the side effects. And knowing the diagnosis of the patient, she's already in the advanced stage of the Hutchin's disease. There's no cure for that. We are just prolonging the agony of her patient. If we're going to continue with the chemotherapy plus the side effects, it's not beneficial anymore to them. It's just going to cause more problems and more discomfort. And so with letter A, that's the reason of why we are selecting letter A. It's because we want to basically respect their autonomy and also their decision. Okay, That is very important. We want to honor their wishes, and we want to make sure that they are receiving compassionate support. And again, this is our goal in palliative care, guys. Always comfort. We don't want anything more invasive procedures. No, not even like life-prolonging alternatives. This is not recommended in palliative care. And it's quite sad when you are dealing with this kind of scenario, but you really need to respect the patient's wishes. All right. Now let's move on to number 17. It makes me sad just talking about this kind of scenarios. It just brings me back to my bedside care that I've done in so many years. Is just quite sad. Number 17. A 52-year-old male with stage 3B Hutchin's disease presenting with significant mediastinal lymphadenopathy causing dyspnea. His oxygen saturation is 88% on room air, and he reports difficulty breathing, especially when lying flat. What should the nurse prioritize? So your patient has stage 3B Hutchin's disease with significant mediastinal lymphadenopathy. And remember, if there is an involvement with the mediastinal lymphadenopathy, this can really cause them to be really short of breath. And so it said here, oxygen saturation is 88% on room air, and he reports difficulty breathing, especially when lying flat. Okay, don't get confused here, guys. Don't get confused. What should the nurse prioritize? I know, we know about the basic nursing steps. What do you think can help the patient's difficulty of breathing? Are you torn between A and B, guys? What do you think? I'm seeing a lot of A's. I am seeing a lot of A's. So let's eliminate one by one. Perform chest physiotherapy. Okay, what is this? Performing chest physiotherapy is not going to be indicated for a mediastinal compression. Not indicated. Yeah, it can cause more dyspnea. All right, letter C, monitor respiratory rate. Do you think that this is going to be necessary? Of course, this is necessary, but do you think that this is going to be immediate as the best answer? No, it will not. Will not be as important compared to the best answer. All right, let's take a look on letter B. Administer oxygen. What do you think would be the reason that it could be the best or maybe not? Well, administering oxygen can help the oxygenation. All right, it can help improve oxygenation. It can also alleviate the dyspnea, right? It can provide immediate relief. Okay? Can provide immediate relief. So we're kind of like tearing them apart here. What about letter A? Elevate the head of the bed. We know that it can, right? It will be helpful in the breathing. But such in a case, guys, that our patient is stage 3B with a significant mediastinal lymphadenopathy. If I have to choose, I actually would have to choose both, right? But I'm actually torn right now between A and B. But looking into the benefits between the two, what can provide immediate relief to the patient's shortness of breath? Will that be elevation of the head of the bed? Or will the oxygen administration give a much more immediate relief? Will it alleviate the dyspnea more compared to the elevation? I believe so. The administration of the oxygen would be prioritized. We can do this as well, but secondary. It will not give an immediate relief compared to the administration of the oxygen. Okay, so here we go. Our patient saturation is 88% in room air. And with a case of 3B Hutchins, do you think that they're going to have some more of like a benefit? They already have a much worse form of cancer here, guys. It might slightly, but it said here, when lying down, we should think about positioning. Yes, that's quite true. Positioning is one of the key in alleviating the shortness of breath of our patient, but will it give a much faster immediate relief to our patient compared to the elevation? No, it doesn't. I know. It's kind of like, hey, I'm just torn right now. But again, look into the benefits, the immediate effects of the oxygen, supplemental effect. I mean, the effect of the oxygen when we are adding a supplemental form. We don't know if it's nasal cannula, mask. It's just a supplemental oxygen. It's not specified. But again, looking into the therapeutic effects of the oxygen, it will better help the patient compared to just elevating the head of the bed. Okay, so we're quite torn here with the situation, but I have to decide something here, and this is going to be the administration of oxygen. Okay, but if the question states what should be the possible sequence of, let's say, what would be the sequence if you are the nurse taking care of the patient? Let's say there is no oxygen cannula in the room available. Maybe in that way we can do the repositioning first, elevating the head of bed. If it's specified like that in the question, maybe we can do elevation, and then we're going to have to provide the oxygen. But this is a general question, just asking what can relieve the patient's hypoxemia, which is basically this one, with the mediastinal lymphadenopathy, with the stage 3, which is a severe form of the lung cancer, or the severe form of the lymphoma rather. The oxygen would better address the shortness of breathing. Okay, let's move on. Number 18, a 53-year-old female with stage 4 Hutchin's disease, presenting with severe fatigue, pallor, shortness of breath, hemoglobin of 7. She is prescribed erythropoietin. What should the nurse prioritize? Stage 4, presenting severe fatigue, pallor, shortness of breath, hemoglobin is 7.5. Prescribed erythropoietin. What should the nurse prioritize? Is it A, administer prescribed erythropoietin? B, monitor the hemoglobin levels? C, encourage iron-rich foods? D, provide rest periods? Severe fatigue, pallor, shortness of breath, hemoglobin of 7.5. Monitor hemoglobin levels. C, encourage iron-rich foods. So what we're going to look for here in this scenario is an intervention that can what? Intervention that can improve the oxygenation. Look for that intervention that can improve oxygenation. This is what we are looking for. Okay. It's already known that our patient's hemoglobin is low. This is very low, and this is expected in this patient, right? So providing rest periods, yeah, that is a good intervention. We should providing them enough rest periods to prevent exhaustion and to manage fatigue, but it will not treat the anemia. Does not treat anemia. What about this one? Encourage iron-rich foods. Will the iron-rich foods sufficient to address the anemia of our patient? This is only going to be applicable to mild anemia. Not sufficient. All right. What about this one? Monitor hemoglobin levels. Will this address the current problem of our patient that has already shortness of breath? Yeah, monitoring is very important. It can, but is it really addressing the patient's issue? Will it provide a much more of like an immediate result? It doesn't, okay? It can help track, monitor the anemia, but it doesn't treat the anemia. That's basically it, okay? It can help monitor the anemia, but will not treat the anemia. So we don't have anything else but letter A, which is administer the prescribed erythropoietin. It is the drug that will cause the stimulation of the red bone marrow to produce red blood cells. That is the reason, guys, why administering prescribed erythropoietin can help in restoring the patient's hemoglobin level. It will stimulate the red bone marrow to produce more red blood cells. And so this will address the anemia. Okay? All righty. The rest periods are also important, but again, it's not going to treat the anemia. That's what we were looking for earlier. Let me check. I think this is the end of our test item today. And so for those who just came into the classroom, we are thanking you for joining us, but we're also encouraging you to check out our website for more information. But yeah, Procrit, that is the name of the drug, Procrit. Erythropoietin. And this is going to be given as what? Subcutaneous injection to boost the patient's red blood cells. Okay, so for those who just joined us, I think there was a message earlier inquiring about the course. Let me see if I can back. Let's see. Is there a course where that can prepare me for NCLEX 10 weeks? Please advise. Oluwaseun Akindele, let's talk. Yeah, I really thank you for your participation today. I hope that this has been helpful for you, especially with the chemo part of the lecture. Also, I just want to thank you for your active participation. I'm seeing more people being much more regular with their attendance, and so I really appreciate for the help, especially with the sharing of the videos and liking the video, which can also help spread the word about our program. And I will see you again tomorrow at 9 p.m. Eastern time. We're going to talk more about the leukemia. We're going to talk about the acute, the AML, and also the different types of the leukemia. So we're going to see you again tomorrow at 9 p.m. Thank you for your attendance today. You take care. But for those who want to stay a little bit, we can chat a little bit regarding your inquiries. So I'll stay in the chat box for you. And again, thank you, and you have a great day and stay safe. Bye-bye.